In this section, we'll switch our focus to hemorrhagic stroke, one type of which is called intracranial hemorrhage. So, just as a review, we talked before about ischemic stroke, which is the majority of stroke cases. Hemorrhagic stroke, as you can see, is much less common. Although it only accounts for 13% of overall stroke, it carries a 2 to 6 times higher mortality rate, and so that's why we spend some time talking about it. Sorry, this image is a little bit blurry, but I just wanted to show you the two different types of hemorrhagic stroke. Intracerebral or intracranial hemorrhage is the one that you see on the left here. This is when an artery within the brain ruptures and causes bleeding. We'll talk about later subarachnoid hemorrhage. This is typically when an aneurysm, which is a weakened area of a blood vessel that kind of balloons out, this can rupture on the surface of the brain, causing bleeding there. So intracerebral or intracranial hemorrhage, again, is when a blood vessel inside the brain gets weakened and then bursts, resulting in bleeding. This accounts for about 10% of hemorrhagic strokes overall. Once the blood starts leaking in the brain, it starts to compress the tissues, because if you think about it, your skull is a fixed size, so the addition of any extra blood is going to start smushing your brain tissue, and that causes increases in your intracranial pressure. Most commonly, this is due to high blood pressure or uncontrolled blood pressure, but it can also be due to things like trauma, tumors, or blood clotting deficiencies, etc. When you look at the symptom onset for intracerebral hemorrhage, it tends to actually be slower than the symptoms that you see with ischemic stroke or even subarachnoid stroke. With those ischemic and subarachnoid, it tends to start all of a sudden. In intracerebral hemorrhage, the deficit does tend to progress over minutes to maybe even hours. So symptoms of ICH are headache, vomiting, increased blood pressure. This isn't so much a resulting symptom, but more like the high blood pressure causes the bleed. You can also have altered level of consciousness. The mortality rate, as you can see, is quite high, almost 50% of patients. Of these patients, about half of the deaths will occur within the first 2 days, so it's very rapidly fatal, and it's actually the most fatal form of stroke overall. And of these, 80% of these patients will never regain functional independence. This is a picture on the right here of an intracranial hemorrhage, so you can see it inside the brain here at presentation, and then unfortunately they weren't able to stop the bleed, so 3 hours later the white part is all the blood, so you can see this was a massive stroke. So what are the risk factors for intracranial hemorrhage? Like I mentioned, hypertension is probably the number one thing. Like ischemic stroke, as you get older, it also increases your risk for hemorrhaging, and of course patients on anticoagulation. So at this point, intracranial hemorrhage really lacks like a magic bullet that's really going to effectively treat and stop bleeding. But overall, our goals through different avenues are to try and stop or at least slow down the amount of bleeding to limit the size of the hematoma. This can be done with blood products and reversal agents that we'll talk about. And the rest of the care is really trying to manage any complications and just provide overall supportive therapy. So we saw in the last slide that anticoagulation is a major risk factor for intracranial hemorrhage. And before we had all the newer oral anticoagulants, warfarin was the most common culprit. So I'm just going to spend some time going over that because we have the most experience with this type of bleed. So if you remember, for the mechanism of the way warfarin works, right, it inhibits the synthesis of vitamin K dependent clotting factors. So hopefully it makes sense that if you have too much warfarin on board, that giving vitamin K can help reverse some of its effects. So vitamin K can be given in a lot of different ways: orally, subcutaneously, IV. In general, the IV form is not typically recommended because of a risk of anaphylaxis. But in the case of intracranial hemorrhage, we're talking about a life-threatening bleed now. So we do prefer the IV form for a little bit faster onset. So it's given 5 to 10 milligrams IV. Even still, though, the onset is going to be around 6 to 8 hours. It takes a while versus PO takes, up to 24 hours. The duration of vitamin K, is quite prolonged because it's affecting clotting factor synthesis. The risk of anaphylaxis, it's reported as less than 1% with IV. And when I started practicing, I thought, oh, every drug has a risk of less than 1%. This never happens. It actually does. I've had a few patients anaphylax with vitamin K IV. So some things you can do to help reduce the risk are to dilute it in, say, 50 mLs of normal saline and infuse it over 30 minutes. Even doing that, I've had patients anaphylax, but it's something you just monitor for and treat if it occurs. So vitamin K we see is, it's kind of slow onset. It takes a while, so you probably have to do something else to help with the bleeding. So fresh frozen plasma is just a blood product. So it's dosed at, 15 to 20 mL per kilo. Its onset you can see is a little bit faster than vitamin K, about 4 hours, and it lasts 8 to 12 hours. The factor content, since it's just taken from donors, can have any of the clotting factors, so that's nice. But you also have no control as far as how much of each factor is in there. Based on the dose, too, you can see that you can get quite large volumes, which may not be preferable for some patients. Because of the large volumes that FFP requires, sometimes variable content of the clotting factors, you can get unpredictable and sometimes incomplete reversal of your INR. In addition, there can be delays because it is blood type specific. You have to type it, thaw it, and then infuse it. So interest in other therapies started, and that led to prothrombin complex concentrates, or PCCs. These are products that are purified from plasma, so it really focuses on the vitamin K dependent clotting factors. So you can see 2, 7, 9, and 10. And in this case now, you can regulate the amount of clotting of each clotting factor, so it's a bit more regimented than FFP. PCC is dosed anywhere from 25 to 50 units per kilo. And in comparison to the other agents, you can see the onset is much faster. We're now looking at 15 to 30 minutes, and it has a moderate duration of about 12 hours. It also avoids the large volumes that you get with FFP. So typically, PCCs require 50 to 150 volume mils once they're reconstituted. PCCs have been studied versus both vitamin K and FFP, and have found to at least be non-inferior. They reverse the INR faster, had a similar rate of thrombotic events, but they did find that it decreased the incidence and the extent of the hematoma growth, probably related to its ability to reverse the INR faster. The PCC product that we have available in the United States is called Kcentra, and it's a 4-factor PCC, meaning that it has factors 2, 7, 9, and 10, your vitamin K dependent clotting factors. So it's indicated specifically for warfarin reversal that's needed urgently in adults with acute major bleeding. So this would count for a hemorrhagic stroke. The dose of PCC again ranges from 25 to 50 units per kilo, depending on the INR that the patient presents with. So you can see, for example, on the far right column, if the patient's INR is greater than 6 on admission, you would dose their Kcentra at 50 units per kilo. You do use actual body weight when you dose Kcentra, but you do cap it off at a maximum of 100 kilos. So your max dose ranges from 25,000 to 5,000 units overall. Kcentra is actually labeled to be given with intravenous vitamin K. So we typically give it 5 to 10 milligrams of vitamin K with Kcentra, again, just because the vitamin K is going to help boost the clotting factor synthesis. Praxbind is a new agent that was just released to help reverse the effects of dabigatran. It's a monoclonal antibody, and it prevents the binding of dabigatran to thrombin. It's indicated, again, for reversing the effects of dabigatran in preparation for emergency surgery or urgent procedures or any life-threatening or uncontrolled bleeding. It's dosed as 5 grams IV, and it can actually be given either as a bolus or infusion, and the package insert doesn't really specify how long you need to infuse it over, but the effects are pretty rapid, and so they've been observed to reverse the effects of dabigatran even by the end of the infusion, and it lasts through 24 hours. Adverse effects reported include hypokalemia, delirium, constipation, and because it is a monoclonal antibody, hypersensitivity has been reported, and some thrombosis. To note, most of the data that led to the release of this agent was from healthy volunteers, but there's currently an ongoing cohort study in patients with serious bleeding or urgent procedures. So, in summary, we just discussed the treatment options for warfarin related intracranial hemorrhage. So, that's going to be IV vitamin K at a dose of 5 to 10 milligrams, and then consider either fresh frozen plasma or prothrombin complex concentrates. Both of these will give you a little bit quicker reversal of your INR while the vitamin K kicks in. As far as the newer oral anticoagulants like apixaban, dabigatran, it's still pretty unclear about the best way to reverse the effects of these agents. If they've been taken recently within the last 2 hours, you can use activated charcoal to help reduce the absorption. Dabigatran has the most options as far as the Prax-bind reversal agent that we just discussed. It's also dialyzable, so you can use hemodialysis to remove it. For apixaban and rivaroxaban, potentially prothrombin complex concentrates may be helpful, but again, there's not a lot of large studies to support the efficacy on this, so we're still getting experience in this area. For heparin-induced bleeds, it does have a reversal agent, which is protamine, and it's dosed at 1 milligram for every 1,000 units of heparin that's infusing. The max dose is 50 milligrams, and you infuse it at a rate of 5 milligrams per minute. If you need to reverse a low molecular weight heparin, you can use protamine, but it is only partially effective for reversing the effects of low molecular weight heparin. So remember, for ischemic stroke, we gave alteplase or TPA, which is a fibrinolytic. And in the case that this causes intracranial hemorrhage, there's again not a reversal agent for this, but you can try to infuse platelets or cryoprecipitate. Cryoprecipitate is a blood product that contains fibrinogen that helps make your fibrin clot. So that's thought to help reverse the effects of alteplase. So moving on to blood pressure control, as we saw in ischemic stroke, in intracranial hemorrhage, you also want to keep a good balance, trying to minimize hypotension that will decrease your cerebral blood flow, and also trying to avoid hypertension that runs the risk of making your bleed even bigger. In intracranial hemorrhage, it was initially thought that hypertension is actually protective because it helps, maintain cerebral blood flow in this acute period. And we used to think that as long as the blood pressure was less than 220, that there really wasn't as much of a risk of expanding the hematoma and the bleed. But new data has come out recently in the Interact trial where they actually randomized patients to a target systolic of either less than 140 or less than 180. And they found that the lower group with a systolic of less than 140 actually had less hematoma growth and a trend for decreased death and major disability. So this is a brand new recommendation that kind of changed our perspective, saying that we don't necessarily have to use this permissive hypertension that we did in the past, and it's actually okay and maybe beneficial to more aggressively lower the blood pressure down to a systolic less than 140. And it's recommended to do this within the first several hours. If, however, your blood pressure is very elevated above a systolic of 220, then you do want to be more aggressive with your blood pressure control by using intravenous drips. And I'll refer you back to your pharmacology lectures about the choice of agents based on their different properties. But I would say in practice, we often use nicardipine for the same reasons that we discussed with ischemic stroke. It's easy to titrate, it has a quick on and offset, and it gets patients' blood pressure under control with minimal fluctuation. As far as secondary prevention goes, you've had a bleed in your head, so the initial thing to do is to hold anything that thins the blood. DVT prophylaxis, such as sub-Q heparin or low molecular weight heparin, may be restarted within the first few days after an intracranial hemorrhage. Things like antiplatelets, such as aspirin or clopidogrel, typically are recommended to hold for at least 1 to 2 weeks after the bleed. If patients have a clear indication for aspirin, you may consider starting it sooner, since low doses seem to have a low risk of bleeding systemically. For patients who are on warfarin or the newer oral anticoagulants, that's recommended to be held for at least 3 to 4 weeks if possible, However, patients with strong indications like mechanical valves or mechanical devices, you may consider restarting them sooner. The blood pressure target for maintenance is actually different than what we saw with ischemic stroke, and this is something that's actually new in the stroke guidelines. They recommend a lower goal of less than 130/80, again, because higher blood pressure is such a big risk factor for ischemic stroke. There's no particular drug of choice for blood pressure management for secondary prevention in ICH, so I would follow the JNC 8 guidelines. Other lifestyle changes that have been linked to risk factors for ICH are again trying to minimize alcohol and tobacco use. Statins we saw was a big recommendation for ischemic stroke for preventing stroke recurrence, but in intracranial hemorrhage, there hasn't been a clear benefit or risk. So if patients have other indications for statins, it's fine to use, but for ICH alone, there's not a lot of evidence to say that it's useful for preventing recurrence. So in summary for ICH, again, the first thing you want to do is stop bleeding. That can be done with surgical interventions, but medication and blood products that we can use include vitamin K intravenously, or things that replace factors directly like fresh frozen plasma or prothrombin complex concentrates like Kcentra. And if they're available, reversal agents for things like dabigatran can be administered. Supportive care, we discuss the different goals for controlling blood pressure in the acute and chronic setting. Just like ischemic stroke, you want to avoid big highs and lows in your blood sugar. And again, the lifestyle changes that we discussed for secondary prophylaxis.